good evening. I'm Melisa Idris, and you're watching The Future is Female, the show where we find the extraordinary in every woman. Now, Malaysia falls below the World Health Organization's 70% target when it comes to cervical screening. In fact, we've only achieved a rate of 13%. But looking at the experience of other countries, Australia is on track to eliminate cervical cancer as a public health threat by 2035. Let's learn a little bit more about their efforts in eliminating one of the most preventable and treatable forms of cancer. Joining me on the show, I have Professor Marion Saville, who's the Executive Director of Melbourne-based VCS Foundation, which is a not-for-profit organization with a goal of achieving cervical cancer control in Australia. Welcome to the show, Marion.
Thank you for having me.
It's lovely to have you here. Now, just a quick note, VCS Foundation is working with University of Malaya on Project ROSE, which stands for Removing Obstacles to Cervical Screening. We had Professor Dr. Wu Yinling on the show recently to talk about cervical cancer and the program ROSE. But welcome to the show. We will touch on ROSE a little bit later,
Sure.
But tell me a little bit more about VCS Foundation. So it's been around for about 50 years now.
Yeah, that's right.
Okay, so a little bit about the work that VCS does.
So we started as a pap smear laboratory about 50 years ago, and this was an effort to improve the quality of laboratory reading of pap smears. We grew to become, we think, one of the premier laboratories for cervical cytology or pap smear readings in Australia. And I joined VCS as the Executive Director about 20 years ago now. Wow. I'm a pathologist by background, but what has become quickly apparent to me is that we're an organisation that was set up to solve a problem with a technology, but the technology has now become dated. We're still interested in the problem. So we've modernised our approach. We're doing HPV tests. We still do a little bit of pap tests, using liquid-based technology, and we're very interested in how digital health can support women to participate in screening, support the follow-up of women who have a positive screening test, and also how that technology can be used to monitor the performance of the program.
Can you explain a little bit about that? What do you mean by the problem is the same, but the technology is dated?
So we're there to prevent cervical cancer. We've always been there to prevent cervical cancer. But pap smears have been incredibly successful in reducing the rates of cancer in countries where we've been able to achieve very high participation and high quality. But that's incredibly resource intensive. And what has happened since I started in my career is the development of very good tests for the virus that causes this cancer, the human papillomavirus. So now, instead of looking down the microscope for the cells that are precancerous and having those women go along to get a treatment to prevent a cancer ever happening, what we do is we test the sample we get from the woman for the virus in the lab. And because that's much more accurate, we don't need to test as often.
Right.
So in Australia, we've gone from pap smears every 2 years to HPV tests every 5 years, and we know we'll be better at preventing cancer because that test is more accurate.
Are pap smears still used in the medical fraternity?
In Australia, pap smears are used if an HPV test is positive, to see if those cells are present and the woman needs to be seen now. But it will depend on how countries roll out their screening programs, whether it will be used in that way or not.
Okay.
And certainly around the world, countries are moving away from pap smears and towards HPV tests. So at a national level, the Netherlands was the first country in the world to do that.
Okay.
Australia was a close second. We were a little bit disappointed to be beaten, but we're certainly what you would call early adopters.
So when did countries start doing this, moving towards the HPV test instead of pap smears?
I believe the Netherlands went in early 2017.
Oh, it's recent.
And Australia made the switch on the 1st of December 2017.
The specific date.
Yeah.
All right, so talk to me a little bit about Australia's efforts to eliminate cervical cancer by 2030. How has the switch to HPV testing helped in achieving that?
So there are two main ways that we prevent cervical cancer. The first is preventing the infection through vaccination. And in Australia, we've been vaccinating our young teenagers around the age of 12 or 13 for over 10 years now. And so that has been happening in the background. But if you want to prevent cervical cancer in all the women on the face of the planet who are too old to benefit from that vaccination, then you need effective screening. So we need to be able to detect the women who've already had an infection, because the vaccine doesn't work once you've been infected. It prevents infection.
Okay.
So if you've had the infection and you're unlucky and you develop a precancer rather than clearing the virus, we detect that through screening. The gynecologist will do a small treatment, and then the cancer never develops.
Okay.
That's the ideal situation.
Okay. So can you talk to me a little bit about what it means to eliminate cervical cancer as a public health threat? Because you can't eliminate the cancer completely.
That's right.
So what does that mean? What is that definition of public health threat?
Okay, so the WHO has commissioned some modelling, which actually was published last week in the Lancet. And my colleagues in Sydney, Australia, at Cancer Council New South Wales, were involved in that publication. And what the draft strategy is saying is that we want to get down to 4 per 100,000 women as an incidence rate. So in Australia presently we're around 7 or 8. I believe Malaysia would be in the low teens. There are some countries in this region who have 30 or more cases per 100,000. That's as common as breast cancer is in our countries. So in those communities, everyone knows someone who's had a cervix cancer.
Wow, in the region, within the region you're saying?
Yeah, within the Asia-Pacific region. Globally, of women dying of cervix cancer, 90% are living in low and middle income countries. This is a disease of a lack of access to appropriate preventative services.
All right, we're going to continue our conversation shortly. Don't go anywhere. We'll be right back on The Future is Female. Stay tuned. Welcome back to The Future is Female. I'm Melisa Idris and I'm chatting tonight to Professor Marion Saville from VCS Foundation based in Australia, talking about cervical cancer control in Australia. Australia aiming to achieve, eliminate cervical cancer by the year 2035. You mentioned just before the break that currently Australia's around 7 per 100,000 cases of women. I'm just wondering, what would it take to achieve that 4 per 100,000, which is the target?
So we believe that a combination of young women who were vaccinated as adolescents coming into the screening age group, together with our enhanced cervical screening with HPV tests being a better, more effective test, will lead to continued reductions such that we would reach that target in about 2035. And that comes from further modelling done by the Sydney group, looking at when we could expect to reach that target.
So when did Australia make put this target on themselves, saying that they wanted to eliminate cervical cancer? How many years have you been working towards this?
So I guess my colleagues in modelling have been working towards it for many years. And of course it's quite complex to understand the uptake of vaccination in various age cohorts, the uptake of screening, the better performance of screening. And that estimate was published October last year. Actually, yes, October last year. No, October 2018.
Okay, a couple of years ago.
Yeah.
Okay. So that's 15 years to go, and the idea is that within 15 years you'd have vaccination in place as well as screening to be able to eliminate this as a public health threat.
So the vaccination's in place, and it's a case of the women who have been vaccinated as youngsters moving into the age group where they're at risk of cervix cancer, and that will happen sort of automatically, and then these improvements to the performance of the screening program.
Can we talk a little bit about the vaccination? perhaps you can help me understand a little bit better. So the human papilloma virus, if I understand it correctly, it is quite a common virus.
Yes.
But there are kind of high risk strains of this virus which could cause the cancer.
That's right.
What are some of the, so how does the vaccine work? You said that it's targeted to a certain age group of females.
Yeah, so the vaccine is recommended to be given to early adolescent girls prior to any exposure to the HPV vaccine. Almost all of us encountered this virus in our life, and certainly all married women may have had the virus, and not even, most of us never even know we've had it.
Okay.
Because for most of us, we just clear that vaccine and we develop natural immunity. But for some women, for reasons we don't understand, the virus persists and it causes changes to the cells of the cervix, which are precancerous and can lead to the development of a cancer. So the idea of screening with pap smears has always been to find those cells at the precancerous stage, and then have the woman have a treatment to take those cells out of the cervix to prevent cancer ever happening.
Okay, and you say to do this every 5 years?
So we were doing it every 2 years or
for pap smears.
2 or 3 years for pap smears, but because we're so good at detecting the virus, and because being infected with the virus comes before the changes, we're protected for a longer time with a negative test.
Okay, all right.
So we're better protected 5 years after an HPV test is negative than 2 or 3 years after a pap is negative.
So an adolescent girl who has gotten the vaccine, is she then immune to, or will she never have the risk of getting cervical cancer?
So the vaccination protects against 2 of the worst types of HPV that account for 70% of the cancers.
Okay.
So we recommend that vaccinated young women still participate in screening because it doesn't entirely eliminate the risk, although it does substantially lower the risk.
Okay, so further in life to still get screening.
So we say that the optimal protection you can have is to be vaccinated as a teenager and screened as a woman.
What is the program like in Australia? I understand you have the HPV vaccination program in Australia. It's been running for many years now. What are some of the best practices that you've noticed Australia adopt in this program?
So I think there are very many similarities with what you do in Malaysia.
What is the Malaysian program, if you don't mind me?
So it's my understanding that Malaysian girls are offered this vaccine in their first year of high school, through school, and that the uptake rates that are reported are very high. And similarly, we vaccinate in the first year of high school in Australia. I think what was done so well here was the community consultation prior to vaccination, and having community support for the vaccine prior to rolling it out.
What does that entail, community communication?
I think a really important part of what happened here, and it was before I had any involvement, was that there was consultation with faith leaders and the people in the community that really parents will turn to ask, is this good for my daughter? It seems to have been done from the outside so incredibly well, because you are reporting such high uptake rates and such trust in the vaccine, which has got very, very good evidence for safety and effectiveness. In fact, it's more effective than we hoped when it first started. And we do know that parents sometimes make these decisions on the basis of emotion, and not always does the evidence-based thing get through to the whole community. And I think it's that leadership that was shown to engage with faith communities and other elders of the community, because the uptake rate was high, and from what I understand continues to be high.
With programs like these, it really is about the education and the awareness, right? So you have to include that in the program. Do boys need the HPV vaccine?
So countries around the world differ on this. Boys can certainly benefit from the vaccine, but from a cost effectiveness point of view, with limited resources, by far the best thing you can do is vaccinate the girls.
I see.
If you can vaccinate boys, it enhances protection of women against cervix cancer. There are other cancers that are caused by HPV, so it protects boys against those cancers, as well as girls against those other cancers too.
Right. You mentioned some of the cultural aspects in Malaysia that we had to take into consideration in rolling out this program. Was that similar in Australia? Did you have any cultural considerations in rolling out such a program?
Look, I think when it comes to the cultural considerations, there's nuances and differences in every country. And so in Australia, we went out about 10 years ago, and I think over time an uptake has been high and continues to be high, and we continue to support parents in making those decisions.
So we talked about vaccination and we talked about screening a little bit earlier. Is one better than the other? I mean, is it better to get vaccinated or is it better to get screened?
It depends how old you are.
Oh, I see.
So really for women who are adult, who haven't had the benefit of being vaccinated as adolescents, there's no point in getting vaccinated. It's far better to screen. But from a population health perspective, these two work together so well. You wouldn't want to choose one or the other program to deliver to your community.
Okay, there you go. All right, we're going to take a quick break and we'll be right back on The Future is Female, so don't go anywhere. Stay tuned. Welcome back to The Future is Female. I'm Melisa Idris. I'm speaking to Professor Marion Saville, who's the Executive Director of VCS Foundation based in Australia. Now, you have a partnership with University of Malaya for the ROSE program, which is removing obstacles to cervical screenings. Let's talk a little bit about how that partnership came to be.
Yeah, so really ROSE is a collaboration built on a friendship.
Oh, that's a wonderful start.
So I met Prof. Wu Yinling back at a meeting in Singapore a couple of years ago. It was called the War on Cancer. And we'd both sort of snuck into the meeting, pushed our way in, and we met each other and immediately shared this vision for the elimination of cervical cancer. And because Australia has still some challenges in terms of equity, but has largely got very effective programs, we were looking for opportunities to assist other countries in how to work together to prevent more cancers in the Asia-Pacific region.
So how specifically did you work together?
So we started with a pilot program, which was really a research initiative, which we co-led. And I think I would describe it as we brought some of the technical laboratory side. Yinling brought, of course, the clinical side, being a gynae oncologist, and of course the local cultural knowledge, which is so important. These programs don't happen in a vacuum, and they have to be tailored to meet the needs not only of the women participating but the workforce. So we trialled a novel approach that was not only new for Malaysia but new for us. So we didn't just take what we do in Australia and say, here, do this. We had a lot of discussions. Yinling talks about design thinking, about how this could be adapted to work within the clinic Kesehatan context initially. And that pilot of 4,000 women went incredibly well, with almost all women who were offered the opportunity taking a sample and participating and saying that they greatly preferred it to a pap test.
It was wonderful because it combined all these components and made the process so much easier. So it really was about understanding what the obstacles were and trying to make it as easy as possible for women and for doctors, for the medical practitioners. Right?
Absolutely.
You mentioned a little bit earlier about digital health, and I think that was one of the components that I thought was particularly interesting because not only was the HPV test self-administered, but also you could get the results privately and almost immediately. And that has been a wonderful, advancement of technology.
It has been, and it's something that we don't do in Australia.
Oh, that's interesting.
So for over 30 years, VCS has run what we call the pap test register, and it records all the pap tests that are done across the state, not only in our own lab, and tracks women and reminds them to come back if they have a positive test or when they're due for their next test. So we've been running that for a long time. We developed this same kind of software, but we've put it in a very secure part of the cloud with very strict access control. But what it means is we can then contact women in Malaysia on their mobile phones.
Right.
we haven't started doing that yet in Australia. We send letters through the post.
Oh,
it's very old-fashioned. And it's just an example of how we haven't taken what we do in one context and just plonked it in.
Right.
It's very important when you run a screening program to understand who you're reaching, to not over-screen some women more often, but really, really important, there's no point in a screening test if you can't be sure you're going to act on a positive test.
Okay.
So what the technology does is it enables the ROSE team to know who needs follow-up. It enables them to see who hasn't had follow-up and to focus their efforts in contacting those women through their phones. And it also ultimately will enable measurement of how well we're going with all of that.
Well, that reminds me a little bit of what you just said about making sure that, you know, the screening is, it reaches everyone. You know, there aren't women who fall through the cracks of the system, so to speak, you know, perhaps low-income women or women who are living in communities that are, you know, geographically difficult to reach. Has that been the case in Australia? Have you seen that happen? So
in Australia, what I can say is when cervix cancer occurs, overwhelmingly it occurs in underscreened and unscreened women. About 80% of cancers occur in women who aren't up to date with screening. Okay. And disproportionately, they are Aboriginal and Torres Strait Islander women. Disproportionately, they come from culturally diverse communities. They might be recent immigrants from countries that don't have screening programs. And they come from women who are of lower socioeconomic status, so they have less means. So what has been so exciting about moving to HPV testing is this opportunity to self-sample. Because for many women who are vulnerable, the thought of having to have that pelvic exam is a significant barrier, and this is the first time we've been able to address that barrier other than what I'll call nagging initiatives, reminding women how important it is. Yes, we know it's uncomfortable, but still come in.
Right.
This has been transformational because we've got the opportunity to say, okay, we get that you don't want to do that, but try this. And overwhelmingly in our pilot studies, we are finding that almost all women will do that.
I'm encouraged to see the ROSE program's work in perhaps reaching out to women in East Malaysia as well. Perhaps this, you know, as you mentioned, underscreened women.
Yes, that's right.
Okay.
So the foundation obviously is a not-for-profit, and it's focusing on B40 women, on women in remote communities where we have the opportunity to offer screening in those communities.
Right.
And certainly want to reach the women who perhaps haven't otherwise got access to screening.
Well, you said you've been working on this for many years now. What have been the real challenges in trying to achieve that goal of eliminating cervical cancer?
I think the biggest challenge we've had in our conventional Pap test program is the reluctance of some women to have Pap smears. So our screening tests aren't perfect, but they don't work when you don't have them, that's for sure. And so being able to reach women with something that's acceptable to them gives us as women control of our own bodies, right? To take our own sample, and we don't have to have anyone else there. That's transformational for the program. And I've been involved in underscreened initiatives for 20 years, and as I say, we understand very well the barriers, but until this came along, this HPV test with the potential for self-sampling, we didn't really have effective answers to the barriers, and now we do, which is why I'm very excited that I think we can get there. I think we can reach women. And the other thing that's so exciting about it is the World Health Organization wants 70% of the world's 30 to 49-year-old women screened. I think that's about 1 billion women.
Wow.
That's a massive scale. We're not going to have enough doctors and nurses to do the traditional exam.
Right.
But we might be able to reach that many women with a self-swab, right? And we found in the clinic Kesiatan they were able to screen so many more women on a day, almost 10 times as many women as they could take Pap smears.
Yeah.
So it's about acceptability, but it's also about the ability to scale to meet the huge global demand.
Amazing. And to think that this could really be achievable within our lifetimes. We could see this cancer eliminated as a public health threat.
Absolutely.
Wonderful. Thank you so much for joining me on the show and for sharing the good work that you're doing with the ROSE program and with VCS Foundation.
Absolutely, my pleasure. Thank you so
Marion.
much.
That's all the time we have on the show today. I'm Melisa Idris. I'll be back with you same time next week. Signing off for tonight. Thank you for watching and have a